wanted to thank you all for coming, and Dr. Chino is going to be giving 3 sessions. The first one today is just a general question and answer session for anything that you might have to ask him about EVAR or thoracoabdominals or his specialty. And then the second one will be on EVARs, and the third session will be on thoracoabdominals. So please don't hold back with your questions, okay? Thank you. Okay, Dr. Chino,
Thank you for
the floor is yours.
In fact, I haven't prepared a presentation. The only reason I have that computer there is because since we're going to start the first thoracoabdominal in my area here, and that will be on July the 11th, I'm going to show you the exact operation that we are going to do on July the 11th. So that's the reason why this is here. And I like to keep these things fairly informal. Informal is because there are things that you see from your perspective that I don't see. And once you ask me, it will stir up an entire discussion about topics that you are interested in. Now, so today I would like to discuss a little the thoracoabdominal aneurysms, and I would start first with your perception of a thoracoabdominal aneurysm. It's almost a tongue twister, so we can also call it the AAA or TAAA, which makes it a lot easier. So do we have any volunteer that would like to say what is a thoracoabdominal aneurysm? Okay. Actually, if there are no volunteers, what I would say is the concept of magnitude of surgery. I would like that in turns you all think of the largest surgery that can be done in humans. So we can start in clockwise fashion. Think a big operation that somebody could receive.
Heart bypass.
Heart bypass. So we have a heart bypass, we skip a little.
It's a brain aneurysm.
A brain aneurysm. We're talking about the biggest operation. Biggest means the operation that encroaches the most in every single body, organ, system, and functions. That's right. If you think about lung transplant, bypass, forget it. Heart bypass is a tiny little operation. Really. It's like a haircut. If you're talking about big operation, like lung transplant, heart transplant, liver transplant, they're all smaller in magnitude than a thoracoabdominal aneurysm. Why do I say that? Because I want to focus your attention on something, which is why thoracoabdominal aneurysms are not done everywhere. And this is the reason. In Canada, there is basically one center where these operations were done in any magnitudes of numbers, and that was where I was at McMaster. We have done 300 of them there. There's no other center in Canada that is even close. Occasionally, some surgeons, usually they're young people, whippersnappers, that they think that is not too difficult, and in fact it isn't once you look at me. They say, okay, I'm going to do it. And so they have small series with a fairly significant high mortality and morbidity. So what are they? Well, as the word says, TAAA, it's easy, but doesn't tell you what it is. But thoracoabdominal aneurysm means aneurysm involving the thoracic and abdominal aorta. Another major difference that people have difficult at grasping is the difference between thoracoabdominal and thoracic aneurysms. They are two different beasts. Thoracic aneurysm, easy operation. Thoracoabdominal, big operation, difficult operation. And when I say difficult, I'm not referring to the technical aspect, but I'm referring to the need of people like you like the intensivist, like the anesthetist, to keep these people alive. So, thoracoabdominal aneurysm are aneurysms which involve simultaneously, and this is the difference, simultaneously, the thoracic and abdominal aorta. Or, by tradition, the entire abdominal aorta above the celiac artery, or to the level of the celiac artery. So, if we look at I thought only Mark was cheap. Okay, so this is brachiocephalic, subclavian, carotid, carotid, subclavian. Then we have the entire aorta. We have to get some extra. So rib cage, the abdomen, groins, umbilicus is about there. So we have the renal arteries, superior mesenteric artery, celiac artery. So it has to be an aneurysm which involves the thoracic and the abdominal aorta, or an aneurysm that involves the entire aorta up to here, above the celiac artery, or the level of the celiac artery. What distinguishes this operation from others? Well, to start with, we have a lot of branches coming out the aorta. It's not a straight pipe. So we have branches here that goes to the intercostal arteries, which also mean to the spinal cord. We have arteries here going to spleen, stomach, liver, intestine, renals, and we had here another one, the inferior mesenteric, to the intestine, and finally we have the arteries going to the legs. All these segments of the aorta, at one point or another during surgery, need to be shut off. And most of these arteries, at one point or another, need to be reattached. And since this is the diaphragm, as we said, this is the chest wall, which is rigid, and this is the abdominal cavity, where most of the aorta with the branches are, you'll understand that particularly in the most extensive form, and we get to there, we will have to open the chest. But it's not like a thoracotomy as we see in thoracic surgery. In thoracic surgery, you have a little cut from here to here, you open, you remove the piece of lung, you close it back. These thoracotomies are very extensive because we have to access to this area and all the way to this area. So we end up with very extensive thoracotomies. We remove usually a rib and we cut the neck of another 1 or 2 ribs in order to gain access. So this alone tells you that the musculoskeletal system is altered. But then we have to divide the diaphragm because we have to get access to the aorta that goes to the diaphragm. So this tells you already musculoskeletal and diaphragm, which is an important muscle of the respiration, is altered. So respiratory problems are significant in these people, both as need of time to wean off a ventilator, and once they're weaned off a ventilator and they come to the floor, you will see they will still have problems with ventilation particularly, and with effusion of the left hemithorax. So are things you will notice. Then, in order to expose all this, we go retroperitoneally. So we go basically, although the cut is in front, we flip everything to the right, and we approach the aorta from the back because it makes it easy. But these are details that you will see better in videos, as I will show you, not today, but some other time. And then we have to reattach these arteries. And what I would like to do is...
Those are new ones there.
No.
Huh?
Do we have a...
Brush?
Okay, well, what I would love to do is tell you how you reattach arteries. You can reattach arteries in two ways. Either you do a bypass to that particular artery. So let's say, which is usually what I do for the left kidney, the anatomy is as such. So let's say I'm replacing that. So this is the graft, this is subclavian, this is the arch there. This is the graft coming down, One technique of reattaching is by cutting a window. I'm telling you because you will read these operative reports and become difficult to understand the beginning. So cutting a window. So if this is the graft, cutting a window means I basically cut the graft, so you have a hole now in the graft. And then you take a patch of the aorta containing the origin of the arteries. So you have now, for example, the celiac artery here, the superior mesenteric artery there, the right renal here, and this is a patch of the aorta containing the orifices. Is that sort of clear? So if you take the aorta and you open it, you look inside, you see the origin of these vessels. So you cut a little patch of the aorta containing those orifices. So this would be, for example, the orifice of the celiac artery, this the orifice of the superior mesenteric, this the orifice of the right renal.
Those are bad, those are good.
These are good?
Yeah.
So, that's nice. So now you can see we have cut a window there. We have a patch there with 3 orifices. We take that and we sew it here. So this part will be now superior mesenteric and kidney. The reason to do a patch is because it's faster. With one anastomosis, we return flow, we return blood to celiac artery, superior mesenteric, one renal. These 3 arteries are very close. The entire patch may be sort of that long, 3 centimeters, 3.5 centimeters. So it leads itself to this type of approach. The right kidney usually geometrically lies outside. So we reattach it as a bypass. So we actually take another graft, attach it to this, and then we do an anastomosis there. So this is a fairly standard way of reattaching. So we have 2 ways, bypasses and patches. The intercostal, similar, sometimes are reattached as a patch, like that. Sometimes are reattached as a bypass. And it depends on the type of patient. There may be a few reattached this way and several reattached with several bypasses. So that's basically the general principle. We have seen already the mechanical ventilation is going to be altered because we have infringed just the mechanics of it, that is the chest wall and the diaphragm. But in order to do this operation, I have to collapse the lung because it's in the way. Somebody proposed to cut it off, but that doesn't sort of work well. So we need to collapse it and push it with a retractor. That will create a non-hypertensive pulmonary edema, intraparenchymal hemorrhages, it creates exudate. So once the lung is expanded, that lung does not work. That's why in intensive care, they may stay a long time. So again, another reason why just look at the respiratory system it will be not working. But then, this little artery there, the one that goes to the liver, has solved an important function. The liver is a more important metabolic function. We make it ischemic, then all sorts of function from metabolism of sugar to metabolism of acid-base balance to drug metabolism, they all get altered. And obviously the kidneys have another cathartic function, and they will be ischemic, they will get the damage. So far we have respiration, musculoskeletal, liver, kidneys. The intestine itself doesn't like to be ischemic because the mucosa will atrophy either during ischemia or postoperatively during the long period of time when we don't feed them. And finally, even the legs get at one point ischemic, therefore compounding the complexity of the injury to the patient. So they are big operation, not only technically, but because from a patient perspective, that basically cause malfunction of almost everything. So, having said that, do they survive? Most of the times they do. And they do if there is a commitment to one thing. And I remember it was my last week, I think, or so when I was in Houston with Crawford, and my program director was DeBakey, but I didn't work with him because it was better not to work with him. But I worked with Crawford where basically I learned this operation, and he really pioneered the entire operation. And so the last week he asked me, if you had to summarize 3 things that you learned this year, what would you say? And there is one that came immediately to my mind. The other one had to fetch them, but one thing that immediately came to my mind is, do not give up. I mean, these people will survive if you do not give up. This is what makes them survive. And it seems obvious, this statement, no, we don't give up at any time. We never give up. Well, I'll put to you that since 1990 that I started my practice, so 18 years, one of my most important struggle, one of the hardest, has been not to have people to give up. That's what I'm telling you. Because it's very hard. See, we are used to regular disease. We are used to a disease where somebody gets an operation, he goes to intensive care, he's very sick, maybe stays there a week, then either he dies or goes to the floor, does well and goes home. These people spend, at the best of the time, a month in intensive care. Sometimes 3 months in hospital, sometimes 6 months in hospital. And if at any point in time you give up, they die. So the commitment to their survival has to be individual and of the overall team. One element of the team gives up, the patient dies. It's not that I like to give talks. Actually, I'm irritated by the camera is there too. But my commitment is to these patients and to this disease. And for this, I'll go through extreme extent. We already had a meeting this morning where I don't operate on these people without having a multidisciplinary meeting. And we'll have a meeting after the surgery, and I wanted that every member of the team is intimately involved, both in the knowledge and in the belief that that's what we want to do. We want to be the center of excellence. The center of excellence is not a word on paper. The center of excellence is that center where all those people that nobody else wants to treat or can treat are treated. And